Hey guys, in this lesson we are going to be talking about dehydration in our pediatric patients. Dehydration can occur very easily and quickly in our pediatric patients. And this is for just a couple of different reasons. So first thing is that our kids have an increased percent of body water compared to adults, as well as an increased body surface area. And this just means that they are going to be losing fluids more easily through their skin. They also have an increased metabolic rate. So fluids and electrolytes, all those things are turning over and being used a lot more quickly. So I've listed our first three things here are some common causes of dehydration in kids. So a common one is fever, decreased fluid intake, which could be for a lot of different reasons, and then things like vomiting and diarrhea from a stomach bug. The last two things that I have listed here are a little bit less common, but are super important to be thinking about when we're talking about dehydration. And those are burn injuries and then new onset diabetes or diabetic ketoacidosis. So what do we need to be looking for when one of our pediatric patients is dehydrated or we're worried they might become dehydrated? So weight loss is probably the most objective measurement that a child has lost fluid. And typically we think that a 3 to 6% weight loss indicates mild dehydration, where something like 10% weight loss actually indicates really severe dehydration. But another way to think about it is that we typically think that 1 kilogram of weight loss is about equal to 1 liter of fluid that they're missing. Other things that we need to be assessing are their vital signs, paying close attention to that heart rate and that respiratory rate. We're looking at capillary refill time. Remember, we want it to be less than 2 seconds. We're looking at skin turgor. We're looking at mucous membranes to see if they're dry. We're paying attention to fontanelles in our infants because they might be sunken if the child's dehydrated. And then we're also paying really close attention to urine output, which for our younger kids just really means talking to parents about maybe when their last wet diaper was. Now, the last thing that I have listed here is very, very important. So I mentioned before that diabetes and DKA can cause dehydration. So we always have to remember to check a blood sugar. A child who has new onset diabetes may actually present with dehydration and weight loss as their primary symptoms. So it's really, really important to know quickly if that's what's causing this dehydration. When we're assessing kids for dehydration, we're probably going to end up putting them in one of 3 categories. They're either going to have mild, moderate, or severe dehydration. And we've made a cheat sheet for you that has a table that's going to go through all the different signs and symptoms that go along with these different categories. But what I want to do here on this slide is just highlight the symptoms that you would see in a child who is in that severe category of dehydration and maybe even on their way to being shocked. Now, before we go through this list of symptoms, I want you to just think about what is actually happening when someone's dehydrated. So when you're dehydrated, you have a decreased amount of water in the body, which ultimately means they're going to have less blood volume as well. And when you have less blood volume, you get decreased or poor perfusion. And that's where all of these symptoms come into play. They are all signs that a patient has poor perfusion. So your most concerning symptoms here are going to be extreme lethargy and sleepiness. That patient may not be responding to painful things like putting an IV in. In your vital signs, you may see extreme tachycardia and rapid deep breathing. And then when you start looking at that patient and you start touching their skin, you'll notice that it's cool. They have mottled peripheries. And then when you assess that capillary refill, you're going to find that it's delayed. So remember, a capillary refill of less than 2 seconds is a good sign of perfusion. But if you press on that skin and it takes 3 to 4 seconds for the color to come back to it, you should be very, very worried about their perfusion. And then probably the very last thing that's going to happen when a kid is severely dehydrated is their blood pressure will drop. Kids can compensate for a very, very long time, so definitely don't wait for a drop in blood pressure to think that something's wrong. It is a very, very late sign of poor perfusion, and you don't want to wait to intervene until you see that blood pressure drop. You want to pay attention to those other signs that are happening well before that. Our treatment of a child that's dehydrated is all about giving them fluids. And we're either going to use oral rehydration solution or we're going to use IV fluids. And then we're going to talk a bit more about the specifics of both of those in just a second. If we are rehydrating a patient, one thing we need to do is make sure that we monitor their electrolytes very, very closely. So we need baseline blood work that's going to allow us to keep an eye on those electrolytes, especially their sodium and potassium levels. Our kids who are dehydrated or even at risk of being dehydrated, they need to be on strict I's and O's, which means that everything that goes in and everything that comes out of their body has to be weighed or measured for accuracy. It's not enough for us to just rely on mom and dad saying they had a bottle of this or a little bit of that. We need to know exactly how much. So when we're rehydrating a patient, our preferred method is to use oral rehydration. And what we're aiming for with this is that we would like to see them take 5 mLs of fluid every 2 to 5 minutes. And one thing that's really important with this is that we need to be using oral rehydration solution. And this is because these actually have electrolytes like sodium and potassium and chloride in them, along with some glucose. If you only use water, that child is at risk for becoming hypoglycemic and then also having really, really wacky electrolytes, especially their sodium and potassium. But if we're using that oral rehydration solution, hopefully we're going to prevent a lot of these issues that can arise. So for more on this topic of how our fluids and electrolytes are interacting, check out our specific course on fluid and electrolytes. So sometimes oral rehydration isn't an option, and it's contraindicated in a couple of different cases for our pediatric patients. And those contraindications are a child who is too sleepy or lethargic to drink without risk of aspirating, and our kids who are breathing too rapidly to drink without aspirating. So the things we're looking at are a decreased level of consciousness. We would not want to give oral fluids, or if they've got an increased respiratory rate. And for these patients, we are going to use IV fluids instead of oral fluids. So if the child is so dehydrated that they need a bolus, you're going to use this formula here. They're going to get 20 mLs of fluid per kilogram, and you're going to use normal saline or lactated ringers. Now, if that child also then needs maintenance fluids, you're going to use something called the Holiday-Seeger method. And this formula is used to calculate how much they can have based on their weight. Now, the first time you see this formula, you're going to think, what the heck? But I'm definitely going to walk you through it on the next slide, and we're going to do some examples. And then we've also created a cheat sheet for you that explains it, and you can refer to if you need a bit more practice. Okay, so here is our formula that we're going to use to calculate a child's 24-hour fluid requirements. And I'm just going to talk through the formula, and then we're going to do some examples as we go along. So if a child weighs 1 to 10 kilograms, you're very simply going to multiply their weight by 100 mLs. So if we have a baby that weighs 5 kilograms, you're going to multiply that by 100 and get their daily fluid needs, which is going to be 500 mLs. Now, if you have a child that weighs between 11 to 20 kilograms, you're going to start with that 1,000 mLs that accounts for their first 10 kilograms of their weight. And then for every kilogram that they weigh above 10 kilograms, you're going to multiply it by 50 mLs. So let's just practice that. Let's say we have a patient who weighs 15 kilograms. So for the first 10 kilograms of their weight, we are going to multiply by 100, and we get that 1,000 mLs that you see written just above here. Now, for the next 5 kilograms of their weight, you are going to multiply by 50. And you get 250 mLs. Okay, and then the next step is just simply to add these two numbers together. So you end up with 1,250 mLs being their 24-hour fluid requirements. For a kid that weighs more than 20 kilograms, you're essentially going to do the same thing that you see above for the 11 to 20 kilogram patient. So you start with 1,500 mLs for that first 20 kilograms of weight, and then for every kilogram that they weigh above 20 kilograms, you're going to multiply by 20. So the numbers that are changing here, for 1 to 10 kilograms, you've got that 150, and then 20. So those are the numbers to pay attention to and be thinking about for your fluid calculations. So I totally get that this is a little bit of a bizarre formula, but I promise if you practice it a couple of times and take a look at our cheat sheet, you will totally get it. Your priority nursing concepts when you're caring for a pediatric patient who is dehydrated are going to be fluid and electrolyte balances, perfusion, and safety. Okay, so what are our major takeaway points for this lesson? So first, just always remember that kids are at increased risk for dehydration. And when you're assessing their hydration status, remember we've got those categories. We have mild dehydration, moderate dehydration, and severe. Make sure you know those red flag symptoms that go along with severe dehydration so that you can identify when a child isn't perfusing well, and then you can know that they are severely dehydrated and at risk for shock. When we're treating, we're replacing fluids, and oral is the best option when it can be done safely. Just always remember to use that special oral rehydration solution to avoid those problems with electrolytes. When we're using IV fluids for our more severe cases of dehydration, make sure that everything is always weight-based. And last but not least, don't forget when we are giving fluids and we're monitoring dehydration, we need to be keeping a really close eye on their electrolytes, and they need to be on strict I's and O's. Okay, you guys, that's it for our lesson on dehydration in pediatrics. Make sure you check out all the resources attached to this lesson. They really are going to be so helpful for you when it comes to putting all of this information together, and they're also going to give you some opportunities to practice those fluid calculations that we went through. Now go out and be your best self today, guys, and as always, happy nursing.